Officially get started, Paige.
Awesome. Welcome. Thank you all for being here. Those I can see on Zoom with me, welcome. Those I can't see in person, also welcome. So thankful that you guys are here today to talk about a topic that I know is very important to me and our panelists. So real quick, we're going to introduce ourselves, just a panel quick name, and why this topic is important to you, and then we'll get started. So my name is Dr. Paige Hudson. I am a licensed professional counselor in the state of Tennessee, and this topic is really important to me after working in community mental health and working in particularly very rural parts of the Southeast Tennessee area, and seeing how the lack of funding for programming, lack of programming, and just lack of overall support was really impacting the not only physical but mental health of the communities I served. So why don't we start with Dr. Gonzales?
Good afternoon. I'm Dr. Jaymes Gonzales. I'm a licensed clinical psychologist in the state of Florida, in the state of Indiana, and in the state of Washington. That's an unusual thing, but that's just how it ended up. My passion for this topic is very paradoxical. I grew up in Los Angeles in a very large Mexican-American family, and I grew up listening to stories of police brutality and mistreatment of family members of mine, namely my grandfather, but a lot of different family members. And that set in motion a passion to work with folks that were treated differently. So people that were disadvantaged, folks that didn't get the same setup that others did. And that led me to what I'll be talking a little bit more about in my work in Alaska. Thank you.
Hello, I'm Leslie Marie Buer. I work for University of Washington, but I live in Knoxville and from Knoxville. So I work remotely for the National Harm Reduction and Technical Assistance Center. So I work with harm reduction programs across the country. I'm also the co-founder of Hellbender Harm Reduction. We are organizing as an organization here in Knoxville. We'll be located in North Knoxville and are also working with First Aid Collective Knoxville. So we are very interested in harm reduction and mutual aid and what that looks like here. Why I'm interested in these issues. So my family has deep roots in rural Appalachian Tennessee, and I've also worked in Eastern Kentucky and Eastern Tennessee getting harm reduction services out there. I formerly worked for Choice Health Network Harm Reduction. And so the rural aspect and the harm reduction aspect are very important to me professionally, but also personally. I have lived experience in substance use, and also as many of us in harm reduction do, we've lost a lot of people who were very close to us to overdose death. So that's sort of where my passion for this topic comes in.
So hello everyone, my name is Andrea Hancock. I am a licensed alcohol and drug abuse counselor, late actors, and I'm also a regional overdose prevention specialist with Davidson County. And it's all about harm reduction. We work under the state overdose response grant. And so our job is to go out and educate and to provide education and trainings to reduce the stigma around the opioid crisis that we're experiencing now, and ultimately to save lives. We believe that when you know better, you do better. So this epidemic is affecting all demographics of individuals. So our goal again is to be that point of contact, to provide the education, to broaden the thinking around the opioid crisis and ultimately to save lives. My why is because I am a person also that has lived experiences. I have 17 years of deliverance, that's what I call it. So I was once a participant of a lot of services or needed a lot of these services. I had to navigate the different systems. So I have a passion for the individual because my whole goal is to inspire hope, because hope in recovery is possible.
Wonderful. Thank you all so much. So as we get started, our first question is, how does substance misuse and mental health treatment differ between urban and rural communities, and what unique challenges do rural communities face? And we can go down the line. We can just pass the mic back and forth, up and down.
Fantastic question. So the data is incredibly clear that rural residents are treated remarkably different and have significantly different access to care than their urban counterparts. Oddly enough, 97% of the country is considered rural. And so when you think about that, and what I said a minute ago, access to care is limited, negligible, and often lacking completely, it's clear that there's a divide. And that divide has components that include us, our expertise in the room. Most of us are here because we want to help and we care about people. So there's a piece of it that we bear responsibility for. There are legal and legislative aspects of it as well. But the divide is very, very clear.
Yeah, I think we certainly know that divide very well. So I want to talk about that divide, but also not have it be over-determinate in some ways. So that divide, especially for harm reduction and substance use disorder treatment, is confidentiality changes drastically from urban to rural areas. I can set up under the bridge in Knoxville a syringe services program and be bombarded, and people come in and they don't really care because like who driving by is going to know that person necessarily, because it's just so it's just much larger. Now, when I was delivering services in Hancock County, that's a whole different scenario, because if someone's driving by, they're probably going to know you, or even know your car, or even know if they even see a dog and that's your dog, they know it's you. So I think that confidentiality piece is really hard. And also I think stigma and discrimination look different oftentimes in rural areas, and it's oftentimes more often based on family. And it may not even be something you did, or it might be something you did when you were in 6th grade and this person is still mad about it, or something your uncle did or your dad did, and then they're treating you poorly because of this sort of familial stigma and stereotyping, which I think is interesting. And yeah, the lack of services is just so difficult. And when you look at the barriers that are there for especially treatment like buprenorphine and methadone, medication for opioid use disorder, in an urban area, you might have requirements to come and get your dose daily, which is still a barrier. That's still very hard. But when you live 10 minutes from your clinic, yes, it's a barrier. When I was in Eastern Kentucky, people were 2 hours from their clinic. So that's 4 hours a day you'd have to spend in the car if you wanted to do methadone. That's impossible. That's your entire life. So I think some of that driving distance is an issue. And yes, we know there are all these inequalities in rural areas. At the same time, because of Medicaid expansion, when I was in Eastern Kentucky, people there had better access to buprenorphine than people in Knoxville do, because they had financial access in an unprecedented way that they had never had before. So there are, of course, these differences, but there's also some similarities. I think sometimes what's happening in rural Tennessee might be more common to rural or to urban Tennessee than it would be necessarily to what's going on in Medicaid expansion states. Or we were talking earlier, there are some states where they are at with substance use disorder treatment and harm reduction, they are living in a different century than we are living. They are so
from my perspective, what I see is a lot of things that they mentioned, but also because the resources, availability, the immediacy of, and when the individual is seeking services or would like to get involved with services, rural areas, again, the services are sparse. They're not as readily available as it is in a lot of the urban areas. So like in the urban areas, we can call someone right on the spot and say, hey, we got someone. When we're doing outreach, we can call someone on the spot and say, hey, we got someone who's ready to go into treatment. And so we know that time lapse is very important, right? You got to catch them when they're ready. So we have services where we can call someone and they say, okay, they can come here and we can get them into treatment. So it's like a respite, but we know that services are not per se available in a lot of the rural areas. So alongside of what they've already mentioned, I see that availability, that accessibility when the individual is ready to get that help. And then also that stigma, I want to reinforce that stigma in some in small towns, small areas, rural areas. It's like everybody know everybody, right? So if your provider may be your high school teacher, that's gonna be a barrier, because I don't feel like the guilt and the shame, the stigma around substance use disorder. Also that, people want family. Sometimes I've seen where families have somewhat discouraged treatment or help because they don't want that to get out. Because people would know that their family is not perfect, So those are some of the main challenges I see. But again, the main thing is the accessibility. Services being accessible, readily available, and what I say, urban areas compared to rural areas.
Wonderful. Thank you all so much. Can you all share examples that you know of any community-based initiatives that have been successful in addressing some of these barriers and in providing treatment for substance misuse and mental health in our rural communities? And what can we learn from those initiatives?
One of the biggest things that I've seen that's made a difference is like mobile clinics or mobile, where they would go and provide services in the actual area, or either providing a transportation to a certain area. Also the telehealth, being able to do it online. Again, I work in downtown Nashville, so we get a lot of telehealth appointments, so individuals have access to those resources. So that mobile and also virtual has been the thing that I've seen has made key differences in individuals receiving the services.
Yeah, I think it's hard to draw examples in harm reduction from Tennessee because the mobile aspects you're talking about is so important. And actually, technically, according to our legislation in Tennessee, we can't really have mobile harm reduction because of the process of approving sites for harm reduction. So for like syringe services and stuff like that, I can't just go to someone's house. So, but I have a lot of friends in Western North Carolina, and so I'll draw from their programming of harm reduction is that they can just go out to somebody's farm and talk to them and hang out with them. Or if someone doesn't want to talk to them, which not everybody wants to talk all the time, you can just drop off supplies on someone's front porch. We're not legally allowed to do that here. So that's, I think, having that mobile aspect is extremely helpful. And then programs like understanding that they're in a rural area, I think is helpful. So for like for buprenorphine, things like that, not requiring people to come in every day, give them enough take-home doses to where they need to check in just every so often and not so often. And I think I would just be repeating everything you said if I went on.
So I mentioned Alaska. I practiced in Alaska for many years. I ran the state's telebehavioral program, which connected rural and remote rural. So in our world there, remote rural meant not on the road system. We connected folks to psychiatric and psychological care. Fantastic program, a lot of access. As you've heard mentioned, access isn't the only thing though. You can put a really good psychologist or psychiatrist on a video with somebody, and if that practitioner isn't culturally competent, it doesn't matter that they have access to them or not. They're not going to be heard. Folks aren't going to come back, and the issues aren't going to be solved. And so I'm glad you guys pointed that piece out, that it's not just access. Access is the starting point. But to be successful, we have to know who we're working with, and that's crucial. If you'll join me on a quick adventure, some of you may have seen this before, I'm hoping not everybody, but if you don't know, all of you carry Alaska around in your right hand. So if you go like this is Alaska. It looks little. It's 665,000 square miles of space. Within that space are 22 different major indigenous cultural groups. So not even counting the rest of the globe. And Anchorage, its biggest city, has some of the greatest diversity range on the planet. The school districts, it ranges, but somewhere between 170 to 196 languages are spoken in the Anchorage School District. So very diverse. The state of Alaska is very diverse. Its indigenous population, which we're used to grouping into Alaska Native, American Indian. That's the terminology, AI. That doesn't do justice to the cultural range that exists in this. And so when we ask practitioners to get on a video, we've done a great job with access, but we're asking them to work with cultural groups that they don't know anything about and haven't taken 5 minutes to learn. That's a problem. I don't know this area very well, but I know from spending 5 minutes on Google last night that Appalachia has a lot of stigma and there's a lot of stereotypes that are false. Fascinatingly enough, the fastest supercomputer in the world is nearby. So it doesn't take very long to just learn a little bit. And the rest of our job is to listen. And so if we can do that, we can be successful. So the programs that I've seen succeed are the ones that listen. I want to read something to you from the Alaska Daily News. This is called A People in Peril. It was a large series. Something is stalking the village people. Across the state, the Eskimos, Indians, and Aleuts of Bush, Alaska are dying in astonishing numbers. By suicide, accident, and other untimely violent means, death is stealing the heart of a generation and painting the survivors with despair. A growing sense of helplessness simmers in the alcohol throughout the bush. Among a growing percentage of Alaska Natives, life has become equal parts violence, disintegration, and despair. An epidemic of suicide, murder, and self-destruction threatens to overwhelm cultures that have for centuries survived and prospered in the harshest of environments on Earth. That's one perspective. This article got a lot of people to wake up. This is a research project that's a community-based participatory research project called People Awakening. And it was basically a counter to that news series. And what they did is go into the community using a community-based participatory model and said, we know you have challenges, but you also have strengths and you have assets and you have things that make you a rich and vivid and living people. And so to answer the question, how do we successfully do that and what are models of success? When we go to the community and we listen, instead of saying, here are all your problems, because we know them, the data is clear on that. But when we listen, we can start to affect change.
Yeah, that just opened up a can of worms. So there's a lot of other things. So the cultural competency piece is important. I've experienced a lot about that. And it's the stereotypes people hold of Appalachia. It's both people coming from outside of the region, but it's also the elite within the region, right? And so there's the people who had the opportunity to go to med school or whatever, and coming back to their community and then holding those prejudiced beliefs, but it's, you know, it's not us, it's like this, it's the poor Appalachians, right? And so there's a lot of class happening there. And of course, Tennessee is diverse. You know, Appalachia's a third of the state, but then you get into Memphis and that's a different cultural aspect with different histories and different histories of discrimination and racism than we have here. And don't get me wrong when I say that, it's different histories of racism for each place. There is obviously still lots and lots of racism in Appalachia. So anyway, there's cultural competency. And I think there's also, and this is written about by some folks at Vanderbilt and then Helena Hansen at NYU, is this idea of structural competency. So understanding the structures that your folks are within. When you're in harm reduction, that means that they are probably involved with the legal system in some way or the other, you know, understanding the other health policies that are affecting them, which I think are so important. And then you noted community-based participatory research, something that a lot of people who use drugs
Sorry.
No, I think we're just.
Yeah, I
moving
think
per
we-
page.
Okay, sorry, I couldn't hear y'all for a second. Thank you very much. So these things you've mentioned, the barriers, including, access and cultural differences. As providers, what are our ethical obligations, not only to these communities, but also on a broader scale, because of economic disparities and limited insurance coverages, does make it hard for providers to also enter those communities. So as providers and as people who care about this topic, what are our ethical obligations and duties to this population and to these communities?
I would like to say education. I'm stickler on educating, that you have to educate yourself in order to become culturally competent or culturally sensitive to the population you're serving. So being willing to get in, being willing to go and to ask the questions to the people that this is impacting and this is affecting. I'm just real big on that education piece and mindfulness, being mindful on cultural biases, being mindful of feelings and, things that may come up and may be barriers to providing care. That the language that matters, that's what I'm taught to, not what's wrong with you, but what has happened to you. And also when you go in and you ask those questions as providers, you're not scared to get involved, to get in the middle, or either collaborate. Because I see that sometimes that's an issue and a barrier with providers with collaboration, right? Having these multiple disciplinary meetings where people are going into the communities, they're providing services and they're saying, hey, what are other barriers that may present where an individual may not be able to receive the substance use and the mental health issues? What are the other barriers? But come together as a one to meet the need of the whole person. So education, being aware of unintentional personal biases, practicing extreme mindfulness, and so you can better serve the individual.
So as a psychologist, my ethics are very clear that I'm not to practice outside of my scope of expertise. And that doesn't mean that I can't work with people I've never worked with before. The first time I worked with a client who identified as Hmong, I had no idea what that meant. I didn't know how to pronounce it. It's spelled very differently than anything I've ever seen. Again, 3 minutes of looking that up, and you will find very quickly it's a people from the mountainous region of Laotia who assisted the US in the Vietnam War, and they have special status to immigrate to the country in a very different way. That took 30 seconds to look that up. Now I have a new perspective on this client. So the ethics around competent practice don't say we can't work with people we've never worked with before, but we have to do it competently. And where cross-culturalism is concerned, there are 1,000 different ways to define that and to view that. To me, back to the idea of listening, cultural competency for me starts with listening and not being the expert. The client is the expert of who they are, of their cultural identity, and how that plays out for them in their daily life, and no two people are the same. So for me, the ethics center around competency, which centers around listening.
So I think two things that are always important to me are to be providing direct services. So be trying to meet the needs of someone in front of you, but at the same time, be working on the structural issues that are negatively affecting their lives. So trying to do both at once, which is difficult. It's hard, but I think we owe it to ourselves and to each other to do that. Another piece that's really important to me is trying to understand and flatten the power differentials between people who are working in organizations and the participants being served, and just understanding how power is flowing through, and also understanding what you can do to have more sort of horizontal leadership, but between clinicians and between staff, but also between staff and between participants. And you're never going to have it completely flattened. That's not how power works. But if you can understand it and try to make those differences, and then for staff to understand the power they have in the community and use that power. So are we writing editorials? Are we getting into debates in the newspaper, as I have done, about what harm reduction means in Knoxville? Like, are we doing these things? I think that's really important stuff to be doing, and to be doing advocacy work. And going back to the education piece of, I'm really interested in how we use education as an organizing piece. So how do we organize people who use drugs to advocate for the services that they want? And so it's all about organizing, and I'm not sure quite how that works yet, but we're trying to build that right now. And I think, and it's also understanding, like you said, not just staying in your lane, but responsibly going into other lanes when it makes sense, right? So for me, like, abolition is a really important, prison abolition, not the other kind of ways people are trying to use that word that aren't right. And so, like, how do we start organizing with people who are looking at the, abolition of prisons, or at least prison reform, because that directly affects our people? How do we look at changing how the family regulation system works, so that the biggest barrier people aren't facing is child protective services? How do we work with people to change all these structures that are negatively affecting their lives?
I want to add one other thing that I think is often overlooked when providing services. And I think it's like an ethical responsibility for me to be well as a provider. We talk about boundaries, which we know are very necessary, but just being well. I see a lot of, sometimes I encounter individuals who I say, you got to know your role and know your role. You got to know your role and know your role, not operating outside of the scope. Also not feeling like you're a savior for the individuals, or you're gonna make them do it. And I struggle with that myself, because sometimes we want more for that individual than what they want for themselves. And so that's not true harm reduction, because you're not meeting them where they are. You're meeting them where you want them to be. You want them to be ready for treatment. You want them to get the help. So I think that also comes from a place sometimes when we as providers are not well ourselves, or we're not taking care of ourselves, or we have that false narrative that because we're the provider, we're in a better place, so we're okay. So I say, always checking your why and listening to your body. Boundaries, self-care, compassion fatigue is a real place, burnout is a real place, and not trying to continue to pour from an empty vessel. So I think sometimes we go into situations that cause more harm than we do help. And I see it often. Or we're being traumatized ourselves, that vicarious secondary trauma. So that exacerbates that unhealthiness in providing services and that trauma that you're experiencing through another individual. So again, taking care of yourself is my ethical responsibility for me to be well and not go into a situation all over the place where I will be all over the place with the individual providing services to.
One quick thing is we also have to recognize how our workplaces can be toxic, and it's usually not from the clients, right? It's not from the participants. It's the hierarchical positions we are in. And so unionizing is great.
Can you all speak to the role of community leaders, teachers, law enforcement, religious leaders in rural communities, and maybe ways, one, to get them involved, get them motivated, and two, how to sustain that in these communities?
Educate. I love that word, educate, and power and collaboration. Multiple disciplinary like meetings, because if it's a child you provide services, you want the school involved. If they have had a legal situation, you want the law enforcement, but being able to educate them about the populations that sometimes see them from a different perspective. I think all coming together so they can see that this person is not a bad person. Maybe the child is acting up at school is acting up because they got issues at home, right? So when everybody come together, things tend to come out. And so being able to say, okay, how can we better serve this child? Does this child need to go to jail, or does this individual need to per se go to jail, or do they need another type of intervention to kind of help them be successful? So I love collaboration, and I don't know why sometimes we I think shy away, and not shy away. Sometimes I see sometimes the agencies believe that they provide all the services. It's like you come here and we got everything. It's no one-stop shop. We all need help. So collaborating, they get scared of numbers. I see sometimes, I know numbers associated with money, is associated with funding, but the reality is it's enough for everybody. And that's my motto. In Nashville, I may provide similar services, but for some reason, it may not be this agency that can help this individual. So I need to be able to form a relationship to be able to refer them to another place and realize that because I lose that number, it's not going to necessarily affect funding for me. So collaboration, communication, and education.
There's a lot of people who don't agree with harm reduction. And it's not actually a thing to agree with or not agree with. It's just denying reality or accepting reality of what actually works. But that said, I think knowing the community, if you're from a community, you know the community, but if you're going into a community, I think really doing deep research on who true partners can be. In my experience in rural Appalachia, this might seem off the wall, but the best partners I've had are all environmentalists who oftentimes they're folks who are from the region or had moved to the region in the 60s and 70s and have done a lot of work around environmentalism. And they tend to be the most progressive people in the county, and they tend to be very supportive of harm reduction. That's been my experience, and those have been my best partners. And so you find your friends first, right? And then I think other friends are oftentimes other people who are doing, behavioral health or mental health work. Those aren't always your friends, but sometimes they are. And understanding who's doing substance use disorder treatment, and especially evidence-based substance use disorder treatment, not like just beating people over the head with whatever. And so understanding that, and then you've got to know your churches, right? In a rural area in a county, there might be one who might support you, but you've got to understand the rest might be advocating strongly against you. And so understanding that. And so I think it's good to find your friends first, and then you can start the education pieces. And I want to say something about law enforcement. The most wonderful thing that a chief of police ever told me was, I like what you're doing, and I'm going to stay away from you and have all my officers stay away from you. And I said, thank you so much. That's the best thing you can do for us. We know from decades of research that having any law enforcement around any harm reduction, people are not going to come in, and why would they? So that needs to be a separation, but it also needs to be, it's a good education point. So we've had some recent policies locally where previously officers were required to carry naloxone versus overdoses in their cruisers. That has been changed. It's now a choice. I do not think it should be a choice for officers to be carrying naloxone. And so that's a problem, and it comes from a lack of buy-in. And I think there's other ways to partner with law enforcement that's keeping them at bay. One thing that I think is great is, one, I don't think anybody should be in jail, but let's face it, there's a lot of people in jail. So let's make sure they have naloxone when they're coming out of jail, and jailers can do that. That's something they can do. And also getting people treatment while they're incarcerated. Again, I would much rather people be getting treatment outside of the incarceration. But if we as a society are going to choose to put such large swaths of our population in cages, then we're going to be advocating to at least get people treatment while they're there. And so in Jefferson County, I think it might be the first successful program in the state. I might be wrong about that, but that they are now have buprenorphine, a buprenorphine program in the Jefferson County Jail. And that took a long time to get off the road. It's being evaluated right now. And I think that is some hope of how we can get some services into these facilities.
One of my heroes is a 25-year-old woman named Deanna. Deanna lived in the town of Kotzebue, which is an Inupiat village of about 2,500 people. And she was the chess coach and the basketball coach. She did choir with the church on the weekends. And she was also a therapist. And she was from Atlanta, Georgia, and had only been there for about 6 months when I met her. She took it upon herself to integrate into the community. Nobody taught her this. But she made herself a part of the community. She connected to the community. She connected to community members. Most importantly, for rural Alaska, a number of things are important, but the village elders are the most important. They're the folks that you get approval to be there basically from. So you nailed it. And then you supplementally nailed it. So I don't have a lot to say other than the collaboration piece is crucial. And you have to be part of the community. You can't show up. You can't say, here I am, expert of all things, hear me roar, because nobody's going to listen to you and you're not going to roar. So collaboration, crucial. Integrating into the community is crucial. And being accepted, genuinely accepted, is also crucial.
Excellent. I think in summary, you all mentioned you've got to find your village, your community leaders, and really get them involved and get them with you, help them understand and collaborate. So I think that's a really, really important takeaway. I want to open it up if anyone in the audience there has questions, or on Zoom for a few minutes of questions if y'all have any.
Sounds to me like one of the things you're talking about is that if we're going to be successful with different groups of people, we need to go in with some of our own personal humility. That we don't have all the answers, that we're going to do what's called. And I think that's maybe hard for a lot of people.
We have to be willing to say that too. I don't know the answers. I don't know your culture, but I'm going to do my homework. We have to be enthusiastic, excited, and humble. Glad you mentioned that.
I think it can be especially hard for people who are from a small town, who are going back to their small town too, to be like, I don't know all the answers, because you haven't lived everyone's experience in that small town. You don't. And so I think it's hard for people coming in from outside, but it's also hard for insiders themselves to realize that. And I think it's really important to approach work humility. Yeah.
I think that for a long time, the stigma was going down about mental health. People were searching out and getting help for themselves. Now, that especially in Tennessee, we have it's all mentally ill people who are carrying the guns. And so if I have a mental health issue, I may not go to somebody for help, because the government may say to that psychiatrist or psychologist or nurse, tell me about the people there who are homicidal or suicidal. I want their names. I think it's really scary now to have a mental health issue or an addiction issue in this state, particularly because of the way that the state has organized the whole thing about gun control being the problem of mentally ill people. You see that as a problem.
I see the bigger problem. So we have a state AG who just got all the medical records for people who are trans from Vanderbilt. That is that's terrifying. And that he is going after the medical records of people who are seeking transgender and abortion care outside of the state. That is terrifying, and we are looking at ways to further protect our data, because apparently HIPAA does not protect our people's data, you know? And so I think we are trying to understand ways that we can best protect that, and I think, yeah, it's concerning how they're getting people's records. Luckily, I'm in harm reduction. I can do almost all of my services anonymously. So I don't have records, but as soon as you come and get an HIV test, you're in the system. And previously I wasn't as scared as that, but now that's changed. How I feel about that.
I just think society, and that's just me, has made it difficult for anyone to say I need help. You know, I mean, when you seem like it's just this persona, and it's so much that people want. It's to me, it's just like social. When I say social media, it's not just social media, but it's so much of a persona to make everyone believe that everything is okay, that it becomes scary to say things are not okay. And it's in their mental health. Okay, so people, because of ignorance, which is not knowing, when they say I have a mental health condition, people go to this worst case scenario of the person that you may want to be in. So now you have this label on you. So it's hard to navigate. It's hard to be accepted or received by people because you have been labeled with someone with a mental health. And because people don't understand about how mental health can be, it's a lot of people you're working with. That's why I say it's a lot of people with mental health is just stabilized through the medication. That, you know, they may be bosses, CEOs, and mental health is not like a death sentence. Mental health, people do go on and do great things with their mental health being treated and their mental health being managed. But I think, again, because that stigma, especially substance use disorder, I've had people even from people who are like in treatment. When I say my name is Andrea and I have lived experiences, or my name is Andrea, or I'm introduced myself, I have experienced chronic substance use disorder. They tell me, well, you're ashamed of being an addict. Well, no, I just may be doing a Channel 5 news segment, and I don't want to have to say that, because still, when I say addict, you think immediately of this worst case scenario. So it's not me not being true to myself. It's just that's how I would like to present. And it means basically the same thing, but different areas and different arenas calls for different language. So yeah, it's just, I think the world has made it scary to say I need help about anything.
It's a big concern. It was a concern for us in the state of Alaska when we voluntarily committed somebody, especially from rural Alaska, and we brought them down to the psychiatric institutes where I was based. They could lose their entire ability to feed their family. Take away their rifle in a subsistence-focused remote rural Alaska village where you hunt to bring in food for the next 3 months. You don't go to the grocery store, but your rifle is your life. That's huge. And for different reasons in different areas of the country, for better or for worse, I'm sure we have opinions on that. Gun ownership and don't take away my guns is a huge barrier. And if I'm asking for help or losing my gun, there's a lot of people that are going to choose not going to ask for help. I'm going to keep my gun. So it's yet another barrier that we face in what's already a field full of barriers. I said earlier that we have a responsibility, and one of our responsibilities, as you've heard from everybody, is that we need to speak up. We need to inform and advocate, speak to representatives, to voice those concerns. Ultimately, the way our society is structured, democratically, with representative leaders, we can't necessarily change everything all the time. But we can be the voice of change, even if that change doesn't happen right away. And so we have to be the voice of change. We have to say things like you just said, that this is a barrier and it's going to prevent people from getting needed help.
I just haven't been up on some of the literature, and you keep using the term harm reduction. Can you define exactly what you're covering with that?
Yeah, so harm reduction was developed in the 1980s, mostly by people who inject drugs and were queer.
because the United States government refused to acknowledge HIV or do anything about it. And so harm reduction was sort of a political and health act of getting people the supplies they needed to stop the spread of HIV among people who inject drugs. Now it's far beyond that, and I think it includes a set of practices that are non-judgmental and non-coercive, that are led by people who use drugs to support people who use drugs and having healthier and safer lives. And so it's a range of services. It could be buprenorphine and methadone access, syringe services programs, new equipment for smoking and snorting safely so you don't spread hepatitis C and other things. And it can also include, so you do mostly naloxone and Narcan access to reverse overdoses. And I think it's also about working against the war on drugs and the harms of criminalization and the war on drugs. So it's a wide arc of things, but it includes very much led by people who use drugs to make everyone's lives better and safer.
And I always say, when I'm trying to explain it to populations who just not familiar with it, I say, well, harm reduction, the definition is the definition meeting people where they are, realizing everybody's not ready or able to stop using. So remember, we want to be aware of those unintentional personal bias. Why don't they just stop? It ain't that serious. It's not that easy for everyone. So meeting people where they are, rather than people going to use. So we want to try to give them a safe way to use. And I say also it's giving people a quality of life until they can choose a better way of life. So you'll be surprised how many people's lives, I mean, I wouldn't be here today if they didn't have harm reduction tools. And it's a lot of wonderful people have started a lot of wonderful programs that because of harm reduction, as much people don't agree with, and I say, whatever floats a person's boat, right? What may not fit you may fit someone else, but harm reduction has saved lives. So many different lives, and it has reduced harm. Because when you think about it, if it's someone who's dealing with, I'm gonna say a sex worker, right? And they're in a married or committed relationship, and for some reason they step out and they, cheat or whatever, that happens. I like to have real conversations, right? So if they're cheat with someone who has a sexually transmitted disease or something, they can take that back home, right? But then even in the circle of people using, if everybody had their own safe drug use tool, it will prevent them from spreading it to the whole, So it's kind of like it benefits in the long run, but again, it saves lives. So it's giving people what I say, a quality of life until they can choose a better way of life. It's not enabling them to use, because guess what they're going to use? Whether they have that safe drug use tool or not, that needle, that condom, the naloxone, they're going to use. But naloxone also is saved because of the crisis we're in right now due to the fentanyl epidemic. I get stories from children. They've had the doctors I've trained, and they had to save their children's life, right? So if it wasn't for that harm reduction tool and them being encouraged to have naloxone, because I say it's one of those things you'd rather to have it and not need it than to need it and not have it. But I get stories often of populations of individuals who never thought that they would have to use it, but they've had to use those harm reduction tools, and they've had to use it with someone that they love and care about. And it's not just the population that they think they're serving, it's someone that's very close to them. So yeah, I'm very passionate.
To give an example of advocacy combined with harm reduction, in the state of Florida until very recently, it was illegal to carry around fentanyl test strips. So that if somebody wanted to use a drug but didn't want to use fentanyl, and they wanted to test to see if fentanyl was in that drug, that was illegal, and they could be arrested for possession of drug paraphernalia for that test kit. Through advocacy, that law was changed, and now that test kit is not considered drug paraphernalia. So that's kind of harm reduction advocacy combining to a good result.
And the exact same thing happened in Tennessee, and we got that passed last year, and we all, a lot of us submitted data to help with that. And are continuing to do so because the law sunsets. But of course, by the time it sunsets, fentanyl, it's not going to be the issue anymore. So, but yeah.
It's a stigma, of course, against people who are abusing drugs or alcohol.
Or even just using.
Using, yeah, that's one thing. And
Yeah, anything, the stigma in the general population has been so great that I can understand where people are coming from that think this risk reduction is bad, because you're helping these people and they should just do it themselves because they're bad people, we don't care.
or it's just certain people, because I say this, and I love to share when I do trainings with populations, again, it's not for me, with I'm like, our office is right near downtown Nashville. We have bridal parties that'll stop by, they'll Google harm reduction, and they'll give us a call. And I've had bridal party buses, I've had stretch harmers, so it's not just people, those people, it's all types of people that come and they get the fentanyl test strips and the naloxone because they know they're gonna party and they know they're gonna use. So again, this benefits not just a certain demographic of people that we had that stigma, or we that thinking around this is for these individuals. Now, a person is at danger of overdosing with the crisis if they use something other than what it's prescribed for, use someone else's medication. How many of us have been guilty of saying, hey, I got a headache, you got a pill, right? And so abuse of a medication is just that, but how many people, it's not just people in chronic substance use disorder, it can be someone who's experimenting. We've had college students who go to very prestigious colleges, and I'm not even gonna say the name, that you think they wouldn't do anything, right? But they've overdosed because of studying and trying to stay up, and their friend gives them something to take something. And again, that's the stories that we get where people have had to use naloxone to save their own children's life. Because again, this crisis is all across the board. So having these harm reduction tools and systems is saving not just people who we think lives, it's saving all kinds of people.
And I know we're running out of time, but this gentleman back here has had this hand up.
Yeah, I think Medicaid expansion is number one. What are some of the other health policy issues that you think the state changing would have the biggest impact on your work?
Stop refusing money from the CDC for HIV work, because we just refused a lot of money for that, and that's absurd. So stop refusing federal dollars. I mean, I'm just gonna go fully for it. I mean, I would love to be Oregon and decriminalize substances and not be putting people in cages because of what they choose to put in their body. So that would be my ultimate.
In the bigger picture, along the same vein, just funding in general. When we don't prioritize funding toward areas that need it, like rural America, which is dramatically underfunded, we're gonna continue to see rural America struggle. When we look at disproportionate anything where minority groups are disproportionately treated and funded, those problems are going to persist. So when school system A looks very different and less diverse than school system B, and school system A gets all the funding and school system B does not, you're going to have the same outcomes that we have. And so until we have equality in things like funding, we're going to continue to have disequality throughout all spheres.
Yeah.
And that would be funding, the one that, and from my understanding, also even practitioners or professionals in like the rural areas, they don't get paid much, so it's not even really attractive to even work in those areas. It's a differential in pay as well, so just funding.
The question in the middle.
To go on with what you were saying, the accessibility of mental health resources, especially for the uninsured. You know, they don't have access to EMDR, which is very helpful for trauma processing. They're limited on what medications they can get, depending on what is funded and what is not. So, you know, sometimes it takes several medications to find what works for you, but if your options are very limited, then your mental health is limited. And, you know, same for people that work in mental health, you know. Some people have to drive, you know, long ways to find a provider that takes their insurance so that they can get those specialized, therapy options, especially in rural areas.
Has anyone ever seen a social worker tell a psychiatrist they can't prescribe a medication? That sounds crazy. I used to see it all the time. And the social worker would say, this person is on a fixed income of $800 a month. That medication costs $2,500 a month. You have to find something else. That is good advocacy from one profession to another for the benefit of that patient, that client, that person.
Yeah, I just wanted to say, as a member of NAMI and a teacher and all this with NAMI, the National Alliance on Mental Illness, we know statistically that it takes on average 11 years for a person from their first psychotic breakdown or episode or whatever. It takes 11 years before they get treatment. That's average, 11 years. And that's not true of somebody with cancer necessarily, or diabetes, but it is of people with mental illness.
Yeah.
So that's an average. An average, so it could be more than higher, it could be.
So what are the ethical considerations of using forced institutionalization when people are not even likely to get care because like they may be uninsured or have other barriers? So like, I feel like that is kind of like when we do screenings, but we don't really have a intention of sending people somewhere. It's like, I feel it's kind of not useful because you're kind of knowing what the problem is, but not really directing them to the solution. So what are the considerations there?
I would go back to advocacy. We have a system where if you have a psychiatric emergency, you can be forced to hospitalization. Usually in most states, it's up to 3 days for an evaluation period. And then most folks are let go after that point with the intention of returning to a community with its arms wide open, ready to serve you with all of your needed services. That's what deinstitutionalization is described as. It's supposed to be, and we all know that's not what it is. So it is a broken system of care where we set people up to get that evaluation. Next time they're not going to ask for help. They're not going to tell us how to do it. If they do go through that process, they're not going to get the care they actually need for a long time at all. So we need to advocate for a different system that includes meeting psychiatric and mental health and substance use disorder emergencies, but doing it in a way that is actually effective, not fragmented system that we have now. Because it does border on unethical, a lot of our minds to do that.
I have seen some agencies where they want to screen people for a substance use disorder at intake and then not do anything about it. And that drives me wild because what you're doing is just stigmatizing someone without then offering any services. So I think that is highly unethical. Just a small example of it.
It's a great question. So we have about 5 minutes left.
Even with 5 minutes?
Less.
We have 2 minutes.
We have one question left.
Anyone have a final question? Dr. Hudson, any last words?
Yeah, I think as a last question, maybe some closing words. What words of maybe wisdom or empowerment or inspiration would you give people who are wanting to get more involved in the rural communities?
Oh, thank you. Collaboration. I would say be willing to get out of your comfort zone and collaborate, to advocate as well, being familiar with your population, knowing what's needed. The laws is like the new 10 care, where a lot of people losing their 10 care, being able to advocate and say things, and being willing to take a loss for a greater win on down the line.
Yeah, I think for me, I really love the history of a place. And I think understanding the history of a place, the history of the institutions in that place is important to understand the structures and the things that are really negatively affecting people's lives.
In a room full of professionals, and I appreciate getting to sit up here, but you're all experts. You could all sit up here. The work that we do is very noble. and it's very hard and it's very rewarding if we allow for the reward. So I would say continue to do the work without putting it all on your shoulders to have success in the work that we do. So again, thank you for your expertise and for being here and being part of a system that cares about people enough to want to help. I really appreciate everyone in the room for that. So thank you.